The Evergreen Media Network Studio, powered by Scott Tree Services.
Hi, welcome to the Preventus podcast, everybody, where we talk about health, wellness, and all things with a focus on prevention. I'm your host, Dr. Felice Haake, and I have allowed my co-host, Dr. Brett Haake, to come back after a series with Melissa Meadows.
Great to be back. Hello, everybody.
Welcome back. Welcome back. So today's episode, it's going to be a series as well. We're going to be talking about heart health. And really kind of understanding, taking a deeper dive with comprehensive lab evaluation in regards to heart health, why your standard lipid panel just might not be enough. So my first question really is, why do we care about heart health? Like, what are some of the statistics surrounding, coronary vascular disease?
Great question. So we're the Preventus podcast. Preventus is Latin for prevent. And I think that prevention is one of the things that we don't do very well in the United States. So why are we concerned with heart health? A couple things. Number one, coronary artery disease. So plaque buildup in the blood vessels of your heart is the number one killer of both men and women in the United States and both men and women throughout the world. So it's the number one killer of both. Number two, I think the last stat I read is about 62% of the time in men and about 46% of the time in women. The very first time that you ever get diagnosed with coronary artery disease will be after you have an event, such as a heart attack or what we call unstable angina, ST segment elevation MI, non-ST segment elevation MI. So we call those cardiac events. So a very high percentage of the time, the first time you're ever diagnosed is after you've already had an event, which means you already have advanced disease. And then the last thing is that the size of the plaque that you have in your artery, in your coronary artery, is actually unrelated to your risk of that plaque breaking off and causing an infarction. What we mean by infarction is the cessation of blood flow distal to where that plaque has broken off. So the size of the actual plaque is unrelated to the likelihood that it will break off. And so these are all things that we need to think about when we're evaluating for coronary artery disease. And the biggest thing is, what do we do? What can we do to take steps to try to prevent?
Okay, so let me make sure I understand this. So what you're saying is that more than half the people who actually have a cardiac event, whether it's a heart attack or unstable chest pain, that they really kind of had no idea until that event.
No idea. And the stats, 46% in women, the first time they present is after an event, and then 62% in men, the first time they're ever diagnosed is after an event. Now, it's not all the time. For instance, when I was in the military, I can remember one guy that we actually took for heart surgery, and he was a colonel in the Army, and he just noticed that he wasn't able to run as far. And so that then led down the path of, he got an echocardiogram and then a stress echo, and then which is an ultrasound of the heart, and then ultimately he got a cardiac catheterization, which is the gold standard that we use to diagnose coronary artery disease. And he had disease that was so extensive that he needed to have an operation. And that guy did not present for the first time with an actual heart attack, but 62% of the time in men, you'll present the first time. So the way that we know that the way that we establish the diagnosis is after you've had an event.
Yeah, and also I've always been taught that women and men can present differently.
Correct.
Men kind of have more of the common, crushing chest pressure, maybe goes into their jaw, radiates into the jaw down their left arm, whereas women tend to have more kind of GI or, abdominal presentation, whether it's nausea, stomach discomfort. So it's really important to know, how it presents. And then the next question becomes, if that's the statistic that you just gave, that more than half of the people walking around have no clue they're walking around with heart disease, then what are we doing in our current conventional healthcare system to really try to understand that and try to figure it out before it happens? Because currently, as I understand, you understand, most doctors only do what's called a standard cholesterol panel. You'll hear us use the word cholesterol and lipid interchangeably, so I just want to kind of set that up for our conversation. But you and I both were taught to just do standard cholesterol panels, but now we have more advanced panels, right?
Correct. And one of the things that we're going to talk about here are these advanced lipid profiles. The one that we use is called the Cardio IQ Lipid Panel from Cleveland Heart Labs. There are a lot of different advanced lipid panels that are beneficial. But I think before we start talking about the advanced Cardio IQ Lipid Panel, let's talk about the conventional lipid panel and what we talk about when we mean good and bad cholesterol, why those terms are probably not completely appropriate to use, number one. But even before we start talking about that, let's just talk a little bit about the way the disease starts. Because I think when you understand the way the disease starts, then you can start talking about, okay, why is it that we want this cholesterol to be lower or this cholesterol perhaps to be higher, or what are the patterns that we look for, starting with a conventional lipid panel and then moving to a Cardio IQ lipid panel. So the bottom line is that in order to develop atherosclerotic vascular plaque, which is what we call coronary artery disease, or what we call atherosclerotic peripheral vascular disease, which is the same disease. It's just in arteries that are not inside the heart. The way that we develop that plaque is what is called an ApoB containing particle. And usually the way that we measure that is what we call LDL cholesterol. That's typically what you hear when the doctor says bad cholesterol. Well, that particle, that LDL cholesterol particle, moves into the vascular wall and it becomes oxidized. Okay, that is the first step in the development of vascular plaque. So what do I mean by oxidized? It moves into the vascular wall and it rusts. Okay, that sets off a whole series of reactions. Okay, we won't go into a ton of detail about the way that that works, but ultimately it results in monocytes, which is a specific type of white blood cell, okay, a scavenger white blood cell, moving into the vascular wall where it becomes a macrophage, okay, that's a scavenger type of white blood cell. That macrophage then engulfs the oxidized LDL, okay, and that forms what we call a foam cell. The foam cell is the basis, is the beginning, the genesis of atherosclerotic plaque, number one. And number two, that's a process that begins to develop in your first decade of life. Yeah. So the risk factors that we talk about when we talk about coronary artery disease, the number one risk factor is age.
Just having a birthday.
Just having a birthday. Age is, and so there's obviously nothing that we can do to stop father time. Okay, right. So the number one risk factor is age. But when you talk about epidemiology and you talk about the use of, for instance, cholesterol lowering medications, statin drugs, the goal is for those medications is to lower what we call the ApoB burden. Okay, when I say ApoB, specifically in the United States, we target LDL cholesterol. Okay, LDL cholesterol. The reason we target LDL cholesterol is because about 85%, under normal circumstances, about 85% of all of your ApoB containing particles are LDL in circulation. Okay. There are three other ApoB containing particles, all of which can become oxidized and start the atherosclerosis plaque forming process. And those three other particles are what's called VLDL, IDL, something called LP(a), and then, like we're talking about, LDL. Okay, so it's that process. It's the ApoB burden, that particle burden, time, and then the amount of oxidative damage and inflammation that your body is going through. So things that cause oxidative damage and inflammation, cigarette smoking is a big one, sedentary lifestyle, obesity, excessive alcohol consumption, and then a big player that I think gets under targeted, and there's not enough, and we've hit this, we've talked about this a lot, is insulin resistance. Yeah. So when we focus on risk mitigation for vascular disease, coronary artery disease, and atherosclerotic peripheral vascular disease, we want to focus on lowering the ApoB burden in a way that maximizes benefit and lowers risk, and then lowers the oxidative exposure and the inflammatory exposure to the patient. So those are the goals when we're evaluating. We're trying to actually prevent coronary artery disease.
So I want to kind of, go back to what you said about, these LDL particles. And I know the smaller they are, the more trickier they are, and they can kind of get into the crevices of the wall. And essentially what's really remarkable, if you think about it and you understood, I know it was a little detailed there, but if you understood what Dr. Brett was talking about, you'll realize it's actually your own body trying to heal itself that actually what causes the plaque. And then the plaque buildup, those white blood cells are kind of saying, okay, there's an injury here, let's fix it. And then ultimately that's what's leading to your heart attack. And then the other thing I wanted to touch on was the talk about that it does start in the first decade of life. They've done studies, post-mortem studies on like teenagers who have, most teenagers death is due to like traumatic deaths, like or car accidents, things like that. And they've done post-mortem studies and they see the beginnings of heart disease as young as like 18, 19 years old. So it is a process of aging essentially. The key is to not accelerate it. And those things that you mentioned, the drinking excessively, smoking, eating poorly, insulin, which would lead to insulin resistance, all of those things will accelerate this process. It'll go faster. And
I think, one of the things that kind of has led me to become obsessed with this is spent as a cardiac anesthesiologist and then an anesthesiologist who's taken sick vascular patients to the OR for a big portion of my career. I see that basically what we're doing is intervening in this disease at end stage at a specific area of the body. And this really is a systemic disease. And also it seems as I've kind of started to look at this, there does seem to be a lot of strong opinions regarding statin drugs. So you have certain people that say that it is that vascular disease is all oxidative damage and all inflammation, and it has nothing to do with your cholesterol or your ApoB burden. And then there are other people that say, oh, well, statins have to be in the drinking water and everybody should be on a statin from the time they're 3 years old, et cetera, et cetera, et cetera. And so the rebuttal to that is, I think, to both of those, what I think are extreme positions, is that cholesterol metabolism and biochemistry and the way that vascular disease develops is highly, highly nuanced and highly, highly complicated.
Yeah.
And I think if it were all oxidative damage and all inflammation, and if it were true that there are no need for statin drugs, then you would not see patients who have a genetic predisposition to a very high LDL burden or high ApoB burden. We call those patients familial hypercholesterolemia, and often these patients need heart and liver transplants in their 20s, particularly the homozygous patients. So these are patients that they're obviously not experiencing any less or more oxidative damage or inflammation than anybody in the general population, but they need heart transplants way earlier than other people in the general population. And so there is a component to ApoB. There are instances, plenty of instances, where cholesterol lowering medication is absolutely the answer. And I think with the Cardio IQ lipid panel, it gives us a little bit better understanding of perhaps where the patient's going to benefit and what we're going to, what we need to do to intervene at the right time. But I think before that, we wanted to talk a little bit about the conventional lipid panel.
Yeah, so what I was going to say is, back to the Cardio IQ. When we say Cardio IQ, it's a test with Cleveland Heart Labs, which partnered with Quest. So you can get it via Quest. But there's also Berkeley Heart Labs and Boston Heart. I mean, there's other advanced lipid panels or advanced cholesterol panels. So to break it down, these advanced panels start, the first part of the panel, it's a very large test, but the first part of the panel is a standard cholesterol panel. So what are the components in a standard cholesterol panel?
Right. So you have your total cholesterol, you have your what's called high density lipoprotein cholesterol, you have non-HDL cholesterol, you have LDL cholesterol, and then you have your triglycerides.
Okay. Which are the good, which are the bad?
Right. So historically, when you go to the doctor, they'll tell you, okay, the LDL cholesterol is the bad cholesterol, the HDL cholesterol is the good cholesterol. It's probably not entirely scientifically appropriate to call LDL bad and HDL good. I think what's more appropriate is to understand the structure of both of these particles and then their function, okay? And so basically, LDL cholesterol simply is amphipathic. So what does that mean? It means it likes water on the outside and it likes fat on the inside. Okay, so it has two fat-soluble substances on the inside, and that's triglyceride and cholesterol ester. And then it has two water-soluble substances on the outside, free cholesterol, and then phospholipids. And then it's defined by a snake-like structure that exists on the outside, and we call that apolipoprotein B. Like I said, apolipoprotein B is on the outside of LDL cholesterol, and it also engulfs VLDL, intermediate density lipoprotein, so IDL, and then also LP little a. Okay.
Does every single LDL particle have an ApoB
Correct.
on it?
It does,
okay.
yes. Now, the LDL particle is not pathogenic. It does not cause plaque if it doesn't get oxidized. It's important to understand that. What is the role of LDL? Okay. The two primary roles of LDL are to deliver phospholipids to cells so they can repair their cellular membrane. Cells are in constant states of repair. And then number two, to deliver triglycerides to cells to be used for energy. Those are the two primary roles. A lot of people think LDL's job is to deliver cholesterol to the cell. A lot of cells make their own cholesterol. So that's a perhaps tertiary or not the most relevant role for LDL. But those are the two primary roles. The high-density lipoprotein, the job and the reason it's called HDL, the reason it's called a good cholesterol is that through a series of enzymatic reactions, okay, it will collect cholesterol from the vascular wall, deliver that cholesterol to an LDL particle, to a VLDL particle, or take it back to the liver and interact with a receptor called SRB1, where it then delivers cholesterol to the level of the liver, and then the liver excretes it ultimately into the bile and into your GI system. So
can I use an analogy just for the listener who's probably like, what? Their brain's fuzzing around. HDL, I've always used this kind of analogy. Maybe it dumbs it down too much. It's kind of like the sweeper of the artery. It's like LDL's kind of like, depositing all the fat, and the HDL's coming around and being like, all right, I got to clean this up. I got to bring it back to the liver and dispose of it.
And so the thing is that HDL in that regard, you're right, collects the cholesterol and then delivers it to the liver. And then LDL basically has cholesterol and can deposit cholesterol in the artery. But again, it's important to understand that there are functions to both. There's an increasing body of data that perhaps suggests HDL function is far more important than your concentration. So there are patterns that we look for in the conventional panel that can predispose or make us a little bit nervous, but really it's function. And then there are tests we can do to test for the function of the HDL. In other words, that process that you and I are describing, sweeping the artery and then bringing the cholesterol back to the liver, that process is called reverse cholesterol transport. And the reality is how good is the HDL at reverse cholesterol transport determines how much risk you have or how little risk you have, in other words. And so one of the other things that we look for on a conventional lipid panel is an elevation of the triglyceride to HDL ratio. Okay. And this kind of gets into the relationship between cholesterol and insulin resistance, which is what we just talked about. And to really understand that, you have to understand that one of the primary areas where insulin resistance starts is at the fat cell. And when the fat cell, these are what we call adipocytes that exist in your abdomen, they have also specific roles as well. When they're not responding appropriately to the effects of insulin, when they're inflamed and engorged, what happens is that instead of incorporating free fatty acids into stored form of energy called triglyceride, they get overwhelmed. They can't do that. Those free fatty acids and triglycerides get released into the circulation, where they cause an increase in the concentration of the free fatty acids and triglyceride. They ultimately get delivered to the liver. Okay, it overwhelms the liver's ability to perform what we call beta oxidation, which is the conversion of fat into energy. You get fatty deposits in the liver. You hear us talking about fatty liver. That is insulin resistance at the level of the liver. And then the liver cells, which we call hepatocytes, also become insulin resistant. When that happens, the liver, one of the jobs of insulin is to shut down the production of an ApoB containing particle called VLDL. Okay, so VLDL gets released into circulation in higher numbers. Triglycerides are also higher. Okay, VLDL gets converted into IDL, then into LDL, and through a series of enzymatic reactions, LDL, IDL, VLDL all become more prone to building plaque. Okay, the other thing is that HDL becomes smaller. HDL is more likely to be excreted by the kidney, so you get this ratio of high triglycerides to low HDL. Your ApoB particle burden can go up, and this can all happen in the setting of an LDL cholesterol that doesn't rise that significantly. And this is why when you look at the diagnosis for metabolic syndrome, which is the way that we diagnose insulin resistance in the United States, the triglycerides being greater than 150, HDL less than 50 in women and 40 in men is a criteria. Those are 2 of the 5 criteria, and LDL cholesterol is not a
Okay.
criteria.
So I'm going to understand this because that's a lot.
Right.
Is essentially what you're saying is that someone could have a normal LDL technically and still have a pretty significant potential for a heart attack or heart disease.
You bring a great point up, is because we so often don't pay attention and measure insulin resistance in the United States, that someone's ApoB particle burden can be higher without a significant rise in the LDL. So it's not showing up on the conventional cholesterol panel, and that is in the inflammatory and the oxidative milieu that's otherwise known as insulin resistance. And this is probably why 50% of the population, when they get diagnosed with type 2 diabetes, already has coronary artery disease. Mm-hmm. So couple main points. Number one, there are patterns that we need to look for on the conventional lipid panel to identify certain problems. We probably need to do advanced lipid panels more often, number 2. And then thirdly, like we've talked about before, we actually need to think about targeting via lab and history and physical examination insulin resistance, and then developing real evidence-based strategies to reverse the insulin resistance.
Yeah, so for like a listener who might have their cholesterol panel at home and they can kind of go back and look at it, well, like what would be something that would be alarming to you as a physician that would say, better look for insulin resistance or metabolic syndrome in this patient? Like what would you see on just a standard cholesterol
labs
panel?
Yeah. Well, so usually with your cholesterol panel, you're getting standard labs as well. And obviously we do the insulin resistance score with our cardio IQ lipid panel, but if you have just standard labs, you're looking for an elevated triglyceride to HDL ratio, and the criteria for metabolic syndrome is triglycerides greater than 150, HDL less than 50 in women, less than 40 in men. But you and I both would argue that once 100. Those triglycerides start to elevate, that can be pathognomonic for insulin resistance. We'll come back to that in a little bit, because one of the important points is we don't evaluate labs in isolation, we integrate. So it's important that, for instance, I might have somebody that has a predisposition genetically to high triglycerides. That person might have a triglyceride of 200 and a fasting glucose of 75 and 8% body fat. They're not insulin resistant, versus somebody might have a triglyceride of 100, a fasting glucose over 100, and an A1C that's starting to jump up a little bit. That patient might, and they may be 23% body fat, that person might have insulin resistance. That leads to the next thing. We also look at fasting glucose. We look at hemoglobin A1C. We look at the triglyceride to HDL ratio. And then one other thing that I think we need to talk about a little bit is we look at something called an alanine aminotransferase. That's called ALT on a comprehensive metabolic panel. And I talked before about the triglyceride and the fatty deposition in the hepatocyte. when the hepatocyte is filled, more than 5% of hepatocytes are filled with fat. We call that fatty liver. When that starts to happen, the liver goes into overdrive to try to convert some of that into energy, and the enzyme that starts to elevate is an ALT. It doesn't mean that everybody with an elevated ALT has fatty liver, but that's a pattern that we look for. If that ALT is specifically rising without a big rise in the AST, then that can be reflective of insulin resistance as well, specifically at the level of the liver.
Okay, so let me get this straight. So triglycerides, we're always talking in our clinic about optimal. Just because the reference range says this is what it's supposed to be, I always tell my patients, remember, reference ranges are based on the population. You're getting the sick and the well combined, so it's skewed. So we look for optimal. So optimally, a triglyceride under 100. Optimally, an HDL over 50 is what we want. Optimally, we want ALTs under 20.
Correct.
Optimally, we want sugar numbers or glucose numbers between 65 and 85. Once it starts going over 85, your radar should go up. This patient's not tolerating sugars, may be insulin resistant. So those are the things we're looking at from a conventional standpoint. So if you guys have your labs, look at them and take a look and see if things have maybe been missed. And you are correct. We have to look at the whole patient, not just one parameter. The entire patient has to be taken into account. So this was kind of the first in our series on cardio IQ lipid panels. We are going to have another series because there's a lot to unpack here. But stay tuned for that series. Thank you.